Welcome, and thank you for joining us in the session NCDs and COVID-19, Understanding Comorbidities and Preparing for Future Pandemics, moderated by Dr. Ratna Devi, Chair at International Alliance of Patients Organizations.
Good morning, everyone, and welcome to Day 2, Session 2. So the topic for today is NCDs and COVID-19, Understanding Comorbidities and Preparing for Future Pandemics. And as we all know, this is the topic that everyone is talking about. Everywhere you go, whether it's the physicians, patients, politicians, financiers, World Bank, bilateral agencies, not-for-profits, everybody seems to be talking about the impact of COVID-19 on NCDs and how it has set back the Sustainable Development Goals by almost a decade. There is a lot of discussion on why more investment is needed in this particular aspect if we have to catch up with what we have lost because of the last 1 year of the pandemic. We have three eminent speakers joining me today for this panel who will throw light on not only from their perspective of what we should be doing, but a research study that has thrown up some results on an aspect that is seldom discussed, which is the mental health impact of the pandemic, and why that is the future silent pandemic, because it is not evident. The impact, even for people who have not been infected by the virus, there has been a huge impact on their mental health because of job loss, because of economic breakdowns, and because of people, confined to homes, social isolation. The social distancing has also led to isolation in some cases, especially for very old people, senior citizens, vulnerable populations, people who cannot move. It has, reduced access to everyday healthcare and has stopped people from taking their medicines because of the fear of contracting the virus if they go to their physicians or their doctors. So without much ado, I would like to introduce my three panelists. Our first panelist is Dr. Anurita Majumdar. She is the Senior Medical Director and Regional Lead for ASEAN in a newly developed organization called Viatris. Dr. Anurita is an oncologist with over 20 years in the pharmaceutical and medical R&D sectors, leading medical affairs, regulatory affairs, and clinical development programs. And she's currently the Senior Medical Director and Regional Lead for ASEAN with the Emerging Markets Division of Viatris. We have also with us Professor Chris Bullen, who is the Director, National Institute for Health Innovation, New Zealand. Welcome, Professor. He's a public health physician and the Professor of Public Health at the University of Auckland School of Population Health, where he's the Director of the National Institute for Health Innovation. He's a leader in non-communicable disease research with expertise in tobacco control and cardiovascular intervention trials, and has a growing interest in the use of digital tools for supporting people to improve their health. He is passionate about the democratization of healthcare and health knowledge, patient empowerment, and health equity. We also have Dr. Shraddha Bhure, who is a medical director, Boehringer Ingelheim India Private Limited. She is a trained postgraduate medical professional in clinical pharmacology with an industry experience of over 15 years in medical affairs, clinical operations, regulatory affairs, and pharmacovigilance across multiple segments of the biopharmaceutical value chain. She's been responsible for the designing and implementation of pre-launch, launch, and post-launch strategies of innovative products. And she strongly believes that risk mitigation strategies are important for managing NCDs. So thank you for joining us. And I will start this session with a brief run through of the rapid assessment of service delivery for non-communicable disease survey that was concluded by WHO NCD. And some of those final, outcomes of that rapid survey was that there is underinvestment in the prevention, early diagnosis, screening, treatment, and rehabilitation of NCDs. And this was pre-COVID. So what COVID has done is this has really driven it deeper into the shelves that, because there was service disruption because of lockdowns and other social distancing measures, the investment into NCDs has now really become an even more, difficult and important issue that needs to be dealt with. And health systems are unable to meet the healthcare needs of people living with and affected by NCDs. There has been severe disruptions, with some countries reporting more than 75% of complete shutdown of routine NCD care, like screening for diabetes, chemotherapy for cancer patients, dialysis for people with chronic kidney disease, and complete shutdown of services for mental health services. And there is a long-term upsurge of deaths from NCDs that is likely because of these disruption of services. The world now is at a critical juncture, and we are now using the word syndemic because there was already a pandemic of NCDs. Now there is a overlying pandemic of the COVID-19, and these two together have actually multiplied the detrimental effects of both the diseases. And what is now happening is that even for people who did not have comorbidities or who did not have NCDs, there are complications of the virus that are emerging, especially cardiovascular and neurological, that still need some data and some learnings to be brought up from the field through research studies. So how are we looking at managing this whole huge problem? And that is what we will be discussing today. And I would now like to invite Dr. Anurita Majumdar to present her views on this topic and what she has to say as an innovator-driven company that has been very actively engaged with patient groups, especially for cardiovascular and mental health in the past. Over to you, Dr. Anurita. I think you have to unmute yourself.
Yeah, yes.
Yeah.
Thank you, Dr. Ratna, and good morning, good afternoon, good evening to everybody. Thank you, Dr. Ratna, for that kind introduction. Many of you may be wondering, what is Viatris? So I'll just take just a quick minute to explain what's Viatris. So Viatris is a newly formed division within which has been formed as a result of a merger between the Upjohn division of Pfizer and Mylan, and this is just less than a month old. The Upjohn division of Pfizer was focused on non-communicable diseases, and many of the examples that I'm going to talk about in the next 7-8 minutes will be the ones that were done as part of my role in Legacy Pfizer Upjohn. My focus today will be to talk about how can industry, academia come together to address non-communicable diseases and particularly in the context of the COVID-19 pandemic, which now we have seen is almost in the 9th to 10th month in this year. So quickly, I think Dr. Ratna gave a very good prelude that we know that there is a deadly interplay between non-communicable diseases and COVID-19. So one is those suffering from chronic comorbid conditions are more vulnerable to get COVID. Also, the complications are mostly seen, the severe complications of COVID are also seen in those suffering from NCDs. But the other important aspect is the word syndemic, is that NCDs were always a silent pandemic. Probably may not have been realized very well, but they already existed. And COVID has just brought about this deadly interplay, which has impacted patients suffering from NCDs in multiple ways. Making them more vulnerable to complications, but also disrupting services. I think it was mentioned that more than 75% of countries have seen and reported disruption of services. Also, the quarantines, the lockdowns, and the travel constraints has impacted access to prevention and essential services and emergency services. So what basically needs to be done, again, this is from the WHO paper as well as a couple of publications, that a multi-sectorial action plan is needed, which should be evidence-based. Multi-sectorial because no one can do it alone. The government, the policymakers, pharmaceutical industry, academy associations, and more importantly, the patient groups all need to come together. We need to support capacity building at all levels to empower the frontline health workers who are the ones who are actually dealing with these patients, ensure continuity of national action plan, exchange best practices, and more importantly, with this pandemic, this teleconsultation and telemedicine has evolved as a solution. But are we all prepared for it? Are the governments, regulations, infrastructure prepared for it? Perhaps no. And that is what is required to ensure that we are better prepared, not only for now till the pandemic lasts, but also for future pandemic. So I will particularly talk about some of the partnerships that we have done. But again, it is not to talk about what Pfizer or John has done, but what can be done in this context to come together to address this. So this on the screenshot, you see, some of the partnerships that we are currently working with in the context of supporting patients or supporting clinical practice gaps or addressing policy issues. I will talk about few of them in today's context, which are more towards addressing health awareness, health literacy, as well as addressing the practice gaps for the frontline health workers. What you see here is some of the examples of our partnerships. So, of course, Dr. Ratna Devi represents IAPO. Early this year, just before the pandemic started, in January, we started an alliance with IAPO to see how together we can come up and map the patient journey for non-communicable diseases. It was so well timed, as Dr. Ratna can say, because this just happened before the pandemic. Now, as we are seeing the outcome of that partnership, we have got a very good patient journey mapping of understanding where exactly are the issues of the patients in each countries with respect to NCD care. Is it issue related to screening, diagnosis, access, or it's a combination? And what are the differences across the countries? How Malaysia is different from Philippines and how Thailand is different from UAE. This framework now in the context of COVID will allow us to have interventions directed towards the impact of patient journey. The second is a partnership that we have with Emirates Airlines, and many of you may have traveled in Emirates when pre-pandemic era. We believe that health literacy is one of the key issues which could be addressed. And in that context, there are a series of infotainment videos that are screened on the, on the in-flight entertainment channel of Emirates. And those videos are now available. In fact, any of you or listening to this, if you are interested, please feel free to reach out and we could support you with these videos because these are not related to any product. These are just videos which help in improving health literacy. There are series of more modules on COVID-19 on how to address topics like hygiene, use of masks, as well as the guidelines. The last but not the least, I will talk about what we've done to address the issue of mental health during the pandemic. This is a partnership with an organization called MIASA. So I believe MIASA was a speaker yesterday. This is a mental health group from Malaysia led by Anita. And this is a group that works very, very closely with patients suffering from mental health conditions, as well as those who have got lived experience of mental health. One of the partnerships that we've done is to work with the Malaysia Psychiatry Association and MIASA to address the different aspects of mental health concerns arising due to the pandemic, either due to job losses or patients already suffering from mental health conditions. How can they maintain their access to care? This was done through a social media, Facebook Live, and we've had great interactions. This is now a continuing intervention that we already do, not only in Malaysia, but in many other countries. Moving from the patient aspect to now, what needs to be done for frontline health workers? Again, this is even though frontline health workers were trained in the past on how to treat NCDs, the pandemic has opened up an entirely newer set of challenges. And we believe collaborations are required to continue empowering them. So there is a partnership that we recently started with World NCD Federation. They're also headquartered in India, in Chandigarh, but they do support a lot of the low middle income countries. And this is to train and empower the primary care physicians or GPs on how to better manage NCDs in the context of COVID-19. This is a series of international webinars, which will also have international experts. We've also done a lot of virtual webinars, particularly focusing on improving digitalization and telemedicine, which is the need of the hour, again, across the low middle income countries. The last but not the least, and this is how we believe we will be able to support towards solutions from a policy perspective. So I represent ASEAN, which is the Southeast Asian countries. We've got a group of policy experts with whom we did a quick survey to understand where exactly the impact to NCD care has happened. And this survey gave us some interesting insights. Based on that, we did a partnership with the Singh Health Duke NUS in Singapore to come up with some recommendations that can be given to the countries to incorporate in their local guidelines. For instance, few of the recommendations that I would like to call out is integrating mental health in primary care is extremely important, because in several countries, including Singapore, where I am currently based, mental health is not integrated in primary care. It is just meant for specialists. However, with the impact that we see, we really need to make sure that every primary care physician is able to understand and address mental health issues. Task shifting to pharmacists also came out as a very important aspect, because at the time of pandemic lockdowns, the patients could reach to pharmacists much easier than physicians. If they are empowered and trained, they can actually take up a lot of that workload and can address that. Similarly, for telemedicine to become effective, a lot of changes in policies will need to be done. And last but not the least, access to the delivery of care is very important. Telemedicine can address consultation and diagnosis, but can the patient actually get the treatment at their doorstep? So those are some of the solutions which will be now made into a publication and hopefully should address some of the issues that have come up due to the pandemic. And this is my last slide, and I will not take much long in this slide, but Dr. Ratna did mention about a survey that was done with the frontline health workers and patients in about 9 LMIC countries. So this was a survey that Pfizer Upjohn worked closely with NIHI, represented by Professor Chris, and he's going to talk about it. So I'm not going to take much time. We worked in partnership with IAPO, WONCA, which is the International Family Physician Group, as well as FIP, which is a pharmacy group globally, to look at survey on patients and frontline health workers to understand impact to NCD care in some of the key diseases like hypertension, coronary heart disease, anxiety, and depression. This survey has given us interesting insights, which actually will not only support a publication, but will also help us address those concerns in those specific countries. Again, what I presented are some examples how industry can work together with academia as well as with stakeholders in this ever-growing pandemic of NCDs, and of course now impacted due to COVID-19. That's probably my last slide. I think we will have questions probably towards the end, but I'll hand it back to you, Dr. Ratna. Thank you so much for giving me this opportunity.
Thank you, Dr. Anurita. And that's a nice way to move on to our next speaker, which is Professor Chris Bullen. And as Dr. Anurita mentioned, IAPO was a part of this study, and we reached out to our member organizations in some of these countries to be able to collect data. I will allow Professor Chris to speak more about it, but just one point that I would like to highlight is that this study is unique in the sense that it did not go to one a group. It looked at primary care physicians, it looked at pharmacists, and it also looked at patients. So while there are many other studies out there on the impact of COVID-19 on NCDs, this is a unique approach that was taken where we took 3 target groups and tried to collect data. So over to you, Professor, to present the results of this survey.
Thank you very much for the introduction, and it's absolutely a delight to have the privilege of speaking to you. I'm late in the afternoon here in New Zealand, but I'm aware some of you are just starting the day. So the background has been, the scene has been set. Just to add to the introduction that Dr. Anurita has provided and Dr. Ratna has provided, we've now had over 55 million people infected with COVID-19 globally, and in excess of 1 million deaths, perhaps more, that we don't know about. And of course, we don't understand fully the morbidity that has resulted directly from the infection or the public health interventions and the disruption that has happened as a result. But just to get that in proportion, non-communicable diseases cause over 41 million deaths per year around the globe. 85% of patients are from low and middle income countries where their health systems aren't as well resourced as wealthy countries to deal with business as usual, let alone disruption from a global pandemic. So I'm going to talk about why we did the survey that you've heard about, how we did it. What did patients tell us? We actually did 2 surveys. One was to frontline healthcare workers, community pharmacists, primary healthcare physicians in 9 low and middle income countries. But what I want to talk about is what patients told us was important to them, and then just unpack and summarize what we think that means. So as you've heard, there's been some work done to date in terms of thinking about how the pandemic of COVID-19 has been disrupting routine care for non-communicable diseases around the globe. And as we know, there's a huge existing problem, big problems with management of basic NCD risk factors and their complications. The WHO undertook a survey which really highlighted some of the issues, but didn't go deep enough, we believe, into trying to understand better the lived experience for patients who've had to put up with lockdowns and job loss, limited access to medication and so forth. So what were the issues for patients? And that was a particular focus of our survey. And as Dr. Ratna has explained, a unique dimension to this work. So what we did was to, through the auspices of IAPO and other partner organizations in 9 countries, undertake an online survey. Patients had to be over 18 years or over, have at least 1 or more non-communicable disease and live on these countries in 3 regions. So the South America, broadly speaking, Middle Eastern region, including Africa, South Africa, Egypt, and Gulf cooperation countries, and then in the ASEAN area, Malaysia, Thailand, and Philippines. And over a month, the month was the month of September through to late October, we recruited participants in the survey. So the partner organizations made contact through their networks, through social media requests, and we were delighted with the response that we got, although it was a little patchy from country to country, but nevertheless, we got some very useful data. So I just want to share that with you, and just to let you know that we had ethics approval to undertake this from the University of Auckland Ethics Committee, and people were approached in an appropriate way and participated through the email invite, and then they were able to go online and answer questions. And essentially there were 4 domains around which we were interested. One was obviously some description of the participant. We didn't need to know their exact identity, but demographic data, and also something about their own NCD experience. But we were particularly interested in the personal impact, what had been happening over the previous months prior to the introduction of COVID-19 into their country, and then what had happened since in terms of their ability to seek adequate health care, and also the changes on their lifestyle. Now, this is a lot of data here, and if you just look at the top, we're seeing the countries, Thailand, Philippines, let's go across South Africa, Brazil, through to Argentina. We've got about 8 out of the 9 countries here. The main things are, we're looking at this table, that high blood pressure and raised cholesterol, cardiovascular disease, fairly similar across experience across the countries, with about 25 to 40 or 50% of people answering the questionnaire with high blood pressure, smaller proportions with elevated cholesterol, about 5 to 20% variance with cardiovascular disease, but diabetes, very common in some of the groups. And so, it's almost 2/3 of respondents from the Gulf cooperation areas, and Egypt reported having diabetes. Similarly, in South America, we had a big response from people with diabetes in Mexico, particularly, and Argentina as well. Anxiety, not so common, but still other chronic conditions, some variation But the big ticket items here, I guess, are diabetes, high blood pressure, which we know are important factors for vascular disease and have huge implications for people's health and longevity. But looking at some of the experience of GP visits before COVID-19 struck, it's quite interesting to see the variation there across countries. So some people don't regularly see a GP, whereas in other countries, much more likely to see them. This will depend on the nature of their condition, obviously. Self-rated health varied, but most people would say they had good health or very good health, despite having their condition, chronic condition, and rating their health today, again, quite surprisingly high levels, even in the midst of a global pandemic. So let's just have a look at what's happened in terms of their reported change in their condition, and importantly, changes in the management of their condition compared to from before the onset of the pandemic to the point in time when they were interviewed, when they were living in the middle of it in many of these countries. So remarkably, most participants said that there'd been no change. And in fact, the proportion of people who said things were worse in terms of their condition was about the same as the proportion of people who said things were better. So they seem to have balanced each other out. But what's more important perhaps at this point in time are changes in the management of their condition. And if you look at the green bars, you'll see that around about 40% of respondents overall said that it was much harder to manage their condition. Very few people said it was easier. So we may see the change in the condition emerging over a longer period of time as people defer treatment, don't have as good access, aren't able to manage their condition as well as they were able to in the past. When we look at levels of concern, again, if we look at the dark bars, that is most people who are concerned as opposed to the light green shaded ones where they weren't concerned, you can see the ranking of concerns. The most important concern for about 70% of all participants was getting infected with COVID-19 if they went to see their doctor. So you can understand why people didn't go. They were worried that the systems and processes in place wouldn't be safe. And then slightly less, but equally, almost 2/3 of participants said they were worried about long waiting times. Now, we all know that waiting times can be long normally, but they were worried that things would be much, much worse. And then there's a large cluster of concerns: increased cost of care, being unable to have adequate diagnostic facility access, being unable to access their prescriptions, being unable to access their usual doctor with whom they'd formed a relationship, a trusted relationship, receiving inadequate quality of care, and even being turned away. It may not have been a real concern, but it was a perception, and it was certainly enough to generate worry and stress for many people. Looking at lifestyle, very interesting to see. This is very similar sorts of data we're seeing from studies conducted all around the world at the moment in terms of things like exercise and eating. And you can imagine if you're in a lockdown, it's very hard to get the same level of exercise that you're used to when you're able to move around freely. So we saw that there was a decrease overwhelming. That's the medium shade green of around about half of people reported a decrease in exercise. Eating healthy food, we know that you know, some people ate a little bit more cakes and what we might call unhealthy food, but equally some people got busy in the kitchen and decided to change their diets and use these experiences of lockdown to instigate a change. Smoking, which is a hugely important risk factor for vascular disease, diabetes, COPD, and all the NCDs, in fact, cancer, etc. Really pleasing to see that in most cases, there wasn't a significant issue. There were some changes, but there were a proportion of people who quit smoking was about the same as people who diminished, who increased smoking. Alcohol, a little bit more alcohol appeared to have been consumed. But if we move over to the far right-hand side, I think this is the most important story we're getting from these data. A lot of people felt stressed, big increases, 2/3 jump up in people feeling stressed. You can see the financial hardship for many people was a problem. That may have been the source of stress. A lot of people feeling isolated, and you can understand this now with the implications of the public health measures and lockdown and shutdown, inability to travel, to engage with their families. So loneliness, stress, financial hardship, and we all understand how that can affect people's mental health. And I'm just finishing up at this point. Really important, how were those barriers to access overcome? Community pharmacists, really important, particularly in Africa, Middle Eastern countries, more so than in the other regions. Home delivery of medication, similarly, well done. About 50% of people received home delivery of medication. Electronic prescribing, not so common in the Latin American countries, more commonly instituted in Africa, Middle Eastern countries. Video consultation, not so great in LATAM, in Africa, where we know the infrastructure for that might be poorer, but much more common in Latin America. Telephone consultation, really important in Africa as a way of substituting for the video consultation, and virtual and digital triage, again, Latin America more common than in, and somewhere in between the Asian countries. So people had workarounds to some of the obstacles that they faced. So in summary, of those who've been infected with COVID-19, this was interesting, about half of the people who said they'd been infected, which was about 5% of the sample, said that their NCDs had been worse. About half of the people who participated in the survey said cost, access to tests, prescription medicines, the relationship with their provider, and being turned away from their provider and waiting times were real concerns for them. But the greatest concern was the fear of becoming infected if they went in a busy waiting room or in some way. But overall, there were some positive and negative lifestyle changes, as I've mentioned, with physical activity and diet. Most patients reported feeling stressed and lonely, and financial hardship increased in about a third. But there was this use of technology, home delivery of medications, and community pharmacists as an important source in some parts of the world. So weaknesses in the delivery of NCD care have been exposed by the COVID-19 crisis. And the mental health burden, no doubt, has increased dramatically as a result of the follow-on effects on stress, loneliness, social isolation, and worries about income and access to care. And so I think we need to monitor much more closely and be able to respond to the developing trends in not only the lifestyle behaviours that are risk factors for NCDs, but also look for opportunities, say physical activity promotion or smoking cessation, that COVID-19 presents. But probably the biggest area of opportunity, I think, is the opportunity to explore, test and pilot innovations to overcome the barriers, which have a long-lasting potential to bring about massive improvements to access post-COVID-19. And that might include greater use of community pharmacists, home delivery of medications, and digital solutions to consultation to overcome financial and other access barriers to care. So thank you, and a particular thanks to all the patients who took part and to our patient advocacy organisations who enabled this survey to be undertaken, and to my colleagues here and who aren't on the screen today. Thank you.
Thank you, Professor. And one of those key takeaways is task shifting. So we have to explore how we can use more frontline health workers to deliver healthcare solutions, especially in terms of in times of this pandemic. Now, in terms of time, we are really short. So let me quickly move to our next speaker, Dr. Shraddha, who will be talking about how stroke, which is very, very badly affected because of stoppage of services, lack of access to hospitals, and moving critical healthcare workers to COVID duties, has impacted the access to care. So over to you, Dr. Shraddha.
Okay, thank you so much, Dr. Ratna Devi, and thank you so much to all the panelists for really covering this extremely important and sensitive topic in the current times. Please excuse me for the background noise, because we know that it's a new normal. We are working all from home, and we have to really adjust to the the so-called new normal in a way of working. So with this specifically, I'm starting my presentation with a kind of an example, because we also saw with Dr. Anurita's example, and also the kind of survey Dr. Chris showed us. There is an impact in the non-communicable disease segment, how do we really visualize it? And I thought that how better than really coming up with the example of a very important non-communicable disease, and how, these kind of a disease which are more time sensitive, the entire impact of COVID-19 has been extremely palpable. Just to begin my presentation, I would like to also give you some facts on so sorry, on the stroke, because stroke is one of the very important, but at the same time, a very devastating medical emergency, and the leading cause of death as well as disability in India and also around the globe. And when we say it's a leading cause of death and disability, the statistics say that it's the second most leading cause of death due to non-communicable disease in the entire world. And that's the reason it's important that the non-communicable disease in the context of COVID, how, it's really critical for all of us to really pay an urgent medical attention to these, and why it cannot be really compromised even in the midst of the healthcare crisis like COVID that we are kind of experienced currently. And that's the reason I feel we as patient organizations, we as healthcare providers, we as government officials and government policymakers need to really work together in this to make sure that these healthcare emergencies, which are not really acute, like a kind of a like a communicable diseases, need to be kind of really taking into account. Specifically in the context of stroke, we always say time is brain, because like in the myocardial infarction or a heart attack, when we speak that it is a healthcare emergency, and we know that in various forms of talks, TV shows, movies, the heart attack or a myocardial infarction has been extremely sensationalized. The similar way, brain attack or a stroke is an equal emergency where every minute matters. And what the statistics speaks about is that every delay by a minute in the treatment of stroke can lead to a loss of around 1.9 million neurons, which are permanently damaged in your brain. And it means that we are talking about a disability or an aging which is advanced by and large, even practically by 36 years, if the entire stroke attack continues to happen. And that's when we realize that these kind of emergencies are extremely important to really look into, in spite of having an emergencies like COVID-19 that the healthcare systems currently are dealing with. There has been some data and evidence in terms of the impact of COVID-19 on stroke care. And there have been some reports of speaking about around a survey of around 426 stroke providers from 55 countries, where it was reported that only 1 in 5 stroke patients are currently receiving treatment of stroke, which is again a very alarming fact, because as we discussed, it's a very time sensitive emergency. And we are also saying that the stroke rehabilitation services at the outpatient care of the hospitals have been affected approximately by more than 53%. So this is approximately, when we speak about the global stats or statistics in the context of stroke, we come back to a specific country where I belong to, India, where we also have seen that the COVID-19 as a condition or as a pandemic has put a massive stress on the healthcare system, and also on the intensive care as well as emergency medicine divisions. And there has been an overall reduction of around 61% on the reporting of the weekly stroke patients in the hospitals. And of course, when it comes to the so-called treatment options, which is the intravenous thrombolysis as well as the endovascular mechanical thrombectomy kind of procedures, there has been a massive reduction in these procedures by around 60 to 70%, which is again extremely concerning situation. And what are the challenges? I think what Dr. Anuvrita also mentioned in her presentation, where there is definitely a lack of awareness. And when we say awareness lack, it is a lack of awareness from the multi-stakeholder perspective. So of course, the patients are not fully aware that it is an emergency. The departments or healthcare systems are also not fully geared up to manage these kind of emergencies. One example being not aware, and the fact remains, because currently, as we look at the disease condition of stroke, we know that the stroke as a condition doesn't give you really the so-called alarming symptoms, the way, say, for example, in the myocardial infarction or a heart attack, where the person has a massive chest pain or a chest discomfort. In the context of stroke, it's more, it starts like a neurological deficit or a kind of a, weakness in your extremities or arms or legs, which does not seem to be an apparent emergency for patients. And to understand that if you do not intervene within the 4.5 hours of symptom onset, it's anyways too late. So that kind of awareness of this being an emergency still does not exist. The second important aspect, specifically in the context of the COVID-19 situation, is where there is a lack of COVID or stroke readiness in the COVID designated centers, because we have realized that the healthcare systems currently, because of COVID-19, has been experiencing a phenomenal shift, because the current systems are fully kind of immersed in managing the COVID-19 situations. Basically, all these patients also come in emergencies or emergency departments of the hospitals, the same places where the also stroke patients or heart attack patients are received. So how, in terms of infrastructure, how in terms of the resourcing, that these centers are able to manage all this patient load is a very important concern. When we speak about the already existing gaps, specifically in the management of such emergencies like stroke management, is also a non-availability of the so-called stroke physician or a specialist neurologist around the clock to manage any such emergencies, or even having a well-equipped stroke unit at the hospital to provide every possible care to the patients. We also know that the ambulance or emergency system in terms of the transport of the patients in countries, specifically in the emerging markets, are really dismal. They are not really fully operational and fully equipped. We do also have very few so-called specialists in the country, or I think the situation is the same also globally, where the neurologist, which also, or that work also as strokeologist, there is a definitive dearth in terms of the number of doctors catering to the kind of disease burden that we talk about. And of course, in the countries like India, where there is a high dependency on a very high-end tertiary care centers in the metro cities to manage these kind of treatments, the patients from remote areas of the countries like villages, etc., and their access to these kind of centers also remain one of the critical points also to address. And this is my last slide in terms of solutions and way forward. This is essentially to give a kind of a visual, kind of impact of how a condition of a non-communicable disease, which is equally alarming as the COVID-19, which is also equally not time sensitive as the COVID-19, and how, in the real, in the situation of, this kind of unprecedented emergency, why we need to, it's a time to really work together as, all so-called critical important stakeholders in this area operational. So important first point from my perspective is awareness campaigns. Here, when we say awareness, because we know that one player simply cannot manage this kind of a need of an hour, because there is a need for awareness from all the so-called players, including the pharma industry, to educate people on the high morbidity and high mortality of the non-communicable diseases, which is not perceived. Of course, patient support organizations, yes. Government needs to take a very high ownership here, because when we speak about the healthcare spends on these conditions are also equally massive. So somewhere I think we need to really have awareness campaigns to make sure that the emergencies like this, which are non-communicable in nature, needs to be also equally driven through all the so-called channels of you can say those social media or any kind of awareness that we speak about. Second important point, in terms of really being ready for managing these emergencies, we still do not have an adequate infrastructure or readiness to manage emergencies like this in the hospital setup, specifically in the context of COVID, where there have been a very I can say chaos, where when a lot of these hospitals have been designated and only as pure COVID centers. There have been some hospitals which are a mix of both, and there are hospitals which are completely non-COVID centers, and how it's important to even refer patients to the proper particular centers is a key. Then something like, a centers of excellence concept, which I also personally believe a lot into, where when there is a need like this, where you need to empower, and this is a time where it is an important need of an hour to empower multiple smaller hospitals or multiple smaller centers to also impart treatment of these kind of emergencies is there. And how do we do that? And that's the reason I feel it's important to have a concept of a hub and a spoke model, where you have hubs like centers of excellence, where these are basically the large tertiary care centers or big hospitals, where they are fully equipped with the expertise, experience, everything, but they simply cannot manage a patient, say somewhere remote in the villages. Are we able to then connect these centers with the smaller centers in a form of telemedicine or some kind of a platform, where you can connect the so-called stroke neurologists from the higher tertiary center to the smaller centers in the remote areas, to be able to then advise and a guide on the CT scans, finding whether you need to go ahead with the lysis or you need some other treatment or not, and at least give a immediate primary attention to the patients as it is a need of an hour today. So if we can look at some kind of kind of establishment of such centers of excellence, we need to now empower the treatment to also a second level physicians. We know that these kind of emergencies, specifically non-communicable diseases, where we do have specialists, but we also have important other link, which is physicians. It's a time to also empower physicians to be able to impart treatment with a guided guidance from the specialist. As I mentioned, the telemedicine infrastructure in terms of really connecting the emergency rooms to the remote areas, to be able to really impart treatment remotely without a patient contact and without maintaining all the so-called COVID protocols in place. Can we do that? Also in the context of emergencies and intensive care units being fully flooded with the emergency like COVID-19, can we also have some kind of establishment of mobile treatment centers like mobile stroke units, where these units are fully equipped, not really as a part of the hospital, but kind of mobile, where there's a patient at the unit which is mobile, is able to kind of reach out to the patient and deliver the treatment. And the last point I would like to mention, and maybe close my talk here, is also the inclusion of such important health emergencies in the non-communicable disease area, like stroke here, under the National Health Mission, specifically in the context of a country like India, where there needs to be a dedicated neurological or such kind of emergency package under the Prime Minister's Jana Arogya Yojana, or it means basically a kind of a Prime Minister's healthcare fund as a part of the government initiative. Can we really look at some kind of such interventions at the level of the governments, to really sensitize governments in terms of the burden of non-communicable diseases and how it is being impacted in the context of COVID-19, and how it has to be a fair balance between an emergency like COVID-19, also along with the emergencies like stroke or MI or a cancer in the area of non-communicable disease. So thank you so much, Dr. Ratna Devi, and thank you so much everyone for giving me this platform to talk to you about a specific concern on the context of stroke. Thank you so much.
Thank you, Dr. Shraddha. And I can see that immediately I can translate all these solutions that you have given to other areas like chronic kidney disease, ischemic heart disease, people on chemotherapy for cancer. These solutions fit everywhere. So it's wonderful hearing from you. We are over time, but fortunately we are into a mobility break. So I'm going to take the advantage of that and take another 5 minutes, because there are a couple of very interesting questions that have come from the audience. The first one is directed to you, Dr. Shraddha, and the question is from a person called Ravinder, who asks, what happens to these 65% of unreported stroke cases? It's a really huge number. And I think this also in some way, refers to a non-existence of registries in the country and a mechanism to understand how many patients are actually reporting with a specific condition. So if you could quickly, in maybe 1 or 2 minutes, yeah.
Correct. So just to quickly summarize on this point is that, yes, there's a massive under treatment which is happening, and we know that the stroke being an emergency, and we know how it translates into, we all know in the very lay language, it translates into a paralysis of the body, which means that a permanent vegetative status for the rest of the life. And it means that it starts, and why I'm again reinforcing this fact of time sensitivity of these kind of diseases, where if you do not act in time, and the reasons being very many, one of the key reasons being a stress or a fear that in case if I go to a hospital setup with these kind of symptoms, whether I would contract COVID or not. And at the same time, currently, the situation for the patient also is a little difficult, because the patient is apparently okay. See, it starts like that in typical stroke patients, where it really starts like a weakness in your arms and legs, need not necessarily be complete paralysis. So what happens is that patient does delay from his side or her side. That's the first delay. And of course, a setup like COVID-19 setup, you have to have now many protocols like, screening for COVID, screening for stroke, and etc. We spend a lot of time, managing all this, where we have, from the protocol or from the guidance perspective, we say that after the person is in the hospital, the treatment has to be given within 1 hour. And the treatment is also based on the CT scan finding, because if the CT scan shows a hemorrhage, you may not even be able to take the treatment. And what happens that in that 1 hour, so much needs to be done. And also there are delays at the hospital. So what happens that in the event, if the treatment is not given, the patient gets into a permanent vegetative state, which is really unfortunate, that really nothing can be done. And, that's the state that, and that's the reason I feel this is a time to really raise awareness that it is okay. And we agree that there is a massive issue on COVID, but the issues like stroke, which will give you a permanent disability for the rest of the life, needs to be sensitized. And here, I think all of us together, of course, our organizations like industry, the pharma industry, the patient support organizations, or even the government needs to really speak about, really continuously speaking about every, second or every minute matters in these situations. We are also doing if you ask me from the industry side, like as a pharma industry, we are doing a lot of awareness campaigns and educational programs. The Indian Stroke Association has come up with a very strong guidance statement on to advising the hospital as to how to really prioritize stroke. So the association are doing their bit of work in the healthcare community. We are doing in the patient community. I would really look forward to support from every one of you to somehow take it up as a our own individual motive, and really make a difference.
Thank you. And the next question is to Dr. Anurita, again from Ravinder, and he's asking, task shifting is a great tool. However, what kind of healthcare services can be shifted, and how long does that take?
Thank you. So that's a very good question. Let me first give the context quickly that the task shifting to pharmacists will depend on the local regulations of the country. There are certain countries who consider pharmacists as healthcare providers and certain countries don't. But if the pharmacists are considered as healthcare providers, then for certain chronic care patients like diabetes and even some of the other conditions, they can actually support in screening, they can support in treatment, and they can support in continuum of care. And continuum of care means that somebody who's already diagnosed and has a prescription for a chronic condition such as diabetes, but needs a routine follow-up and is unable to visit a primary care physician or GP where an appointment is needed and there is a long waiting, the pharmacists can step in. Now, how much time it requires depends on the training level, and that's where the investment is required, because pharmacists need the training to do this task. And that's where investments from all stakeholders are required. There also needs to be an incentive for them to do that. Why would they do that? Some kind of a recognition, some kind of a support to them so that they do this task willingly. So the time will depend on their education and training level. Investment is a motive that everybody has to come together, and of course the local regulations of the country has to support.
Thank you so much. Thank you to everyone. We are now completely out of time, but we had a very good discussion, and I really enjoyed everyone's thoughts on this. Thank you so much.
Thank you.
Thank you, Ratna. And thank you, everybody. I think it was a very good session. And I will ask Will to move the audiences back to the auditorium and wait for us. And we'll personally come and thank you and invite you to our next Asia Pacific. and continue working with you through our training project on stroke and also a project with the Patient Academy in Innovation and Research. Thank you all. Thank you.
Fantastic.
Thank you.
Thank you so much for
Thank
the
you.
opportunity.
Thank you so much.
Bye-bye.
Bye-bye, everybody.
Bye.